Good afternoon, ladies and gentlemen. Thank you very much for joining us on our fifth instalment of Now You're Up to Date. And our first speaker is Dr. McColgan. Dr. McColgan he's a medical graduate of University of Glasgow, obtained honours degree in physiotherapy from University College Dublin. He also holds a Master's in Sports and Exercise Medicine from Trinity College, is a Fellow of the Faculty of Sport and Exercise Medicine, and he is a sports physician working across the UPMC network, and he's based in Waterford. He's also had many years working with the Meath senior football team and the professional Premier League, where he was a doctor for Dundalk. So I'm just going to ask Dulta to now share his screen and welcome him to talk on the first presentation with concussion, the clinical profiles. Dulta, you're very welcome if you want to share the screen.
Pat, thanks for the introduction and thanks for asking me to speak today. I'll be talking today about the clinical profiles of concussion, something that's probably less well known, and something I think is important that anyone who's kind of, I suppose, identifying concussion and then treating a concussion, it's important that they're aware of the different clinical profiles that we have. So that's the content of my talk today. It'll be very brief, about 10 minutes or so, and I think there's time for questions at the end. So just bear with me, and we'll address any questions that we have. Just an introduction on the UPMC Concussion Network here in Ireland. It's a nationwide network that we have with doctors all over the country and associated rehab teams as well. So I'm based out of Waterford in the sports medicine clinic of Waterford, but we do have doctors nationwide. And then our national lead physiotherapist from a rehab point of view, Derek O'Neill, is in Waterford with me as well. So I work very closely with Derek and then other members of the network as well, obviously. And we regularly feed back to Pittsburgh, and one of our colleagues from Pittsburgh, Anna, is going to speak today as well. So it's great to have her expertise as well. So I suppose we need to, first of all, think about what exactly is a concussion and how does it happen. So it is a traumatic brain injury, and it's caused by a direct blow to either the head, neck, or body. So it's not always a head-on head collision. It can be an indirect blow to the body, so neck and body, and that causes an impulsive force into the brain. And it says in this definition here, during sport and exercise related activities, but we all know from our clinics that it's a lot more than that. It can be work related, it can be road traffic accidents, a slip, trip, or a fall. So it's important just to bear that in mind when you're assessing something, that it's not always just sporting related. When a concussion, I suppose, occurs, is it causes a neurotransmitter a metabolic cascade, and then this is then at a cellular level, obviously, with an axonal injury, and that can cause change in blood flow and inflammation, and this is what affects the brain, and that's what causes the symptoms. So we always have to remember as well that when a concussion occurs, it's not straight away that you get the symptoms. The symptoms evolve over time and over minutes and hours. Some come, some go, and most of the time they resolve within a number of days. And they're the ones that we don't see, but the ones that are prolonged are generally the ones that we do. So concussions can resolve by themselves, but sometimes they are prolonged, and that's when we come in and try and manage things to get people back to play, back to work, back to just even living a normal life. Okay. So I suppose to manage a concussion successfully, we need to be able to recognize it. And that's very important in the sporting sense, that we recognize a concussion and remove the player from play. The reason being is the longer you leave a player that's concussed continue to play, that can increase the amount of time that it takes to recover. So it's really important that we recognize this and then remove. So the concussion evaluation starts pretty much at the time of impact, and it's a very comprehensive evaluation that's done. So this starts kind of on the sideline when the clinician, before they even enter the field, they suspect a concussion, and then when they reach the player, start the kind of assessment. Okay, we need to make sure that while a person or a player is concussed, that we eliminate any kind of additional head injury exposure. So that's removing the player from play and then starting treatment. And then the really important thing with management of concussion, and I think Anne's going to touch on this as well, is how we rehabilitate our injured players or individuals, and that's through active rehabilitation. So by determining what your concussion profile is, that can determine how you rehab it and how you rehab it actively. So let's take a look at the signs and symptoms of a concussion. I'm sure all here are well aware of what these are. So it's that kind of dazed, vacant and confused, and that's usually what happens straight away when you go onto the field. You see the players a bit dazed, they're kind of don't really know where they are, and they might be even a bit confused, and you often ask them what the score of the game is, and they mightn't even know if they're disoriented, they mightn't even know where they are. And then it's the unusual behavior as well. You might get them to stand up and they're uncoordinated, or if they've been concussed and they've continued to play, that they might just not be the player that they usually are. You may see some vomiting and loss of consciousness as well. How does that present from a symptom point of view? Generally, they can be dizzy, the classical headache, which I think a lot of people would associate a concussion with, and then the visual changes. So that double vision, blurred vision, might be the classical seeing stars, and then that ringing in the ears as well. Later on, you might see a bit of weakness and fatigue. And a lot of the time when we do our evaluations in the clinic, we ask about amnesia, because there is memory loss that would commonly occur with a concussion. So they might even remember the incident themselves, and that's might be a bone of contention with the player. They don't remember a bang to the head, and they want to continue to play, but they don't really know where they are because they're confused. And then later on as well, when players or individuals present to the clinic, we often have them present sensitive to light and noise, and it wouldn't be uncommon to see people come into the clinic in the middle of winter with a pair of sunglasses on. And all of these things that they present with creates an anxiety and a nervousness, because they're worried about their injury, and they're worried about getting back to play, and they want to just get back and do the thing that they love. So that's something that we really need to respect as well, is how this is affecting the individual and their mood, and if they develop any kind of mental health issues or anxiety surrounding this. So this slide here is probably the one that we'll see kind of recurring throughout the talk, and that's about the clinical profiles of concussion. So the profiles of concussion are really important to understand, that it's not just bang to the head, concussion, you've got a headache, that's it. There's a lot more to it than that, and I'm sure we've all dealt with the various different profiles of the concussion. So you can see here there's 6 things kind of in that Venn diagram, and they're all overlapping and they're all kind of interchangeable. Now you mightn't have a concussion with all 6 or all 5 even, but you may have 1 or 2 that present kind of primary, secondary, tertiary, and a little smattering of the others as well. So vestibular, that's we're looking at balance and how that the vestibular system might be affected. The ocular system is to do obviously with the eyes and how the eyes move, so the ocular motor system really. We know that concussion can cause issues with cognition and also fatigue, the classical headache with the post-traumatic migraine, and then that anxiety and mood issue that I touched on as well. And we always have to be mindful of the cervical spine as well, and make sure that in our assessments we're clearing it, making sure that there's no injuries to the cervical spine. So you'll see here on this slide here how the various profiles present. And if you look at it kind of closely, and I'll go through each one now in a second, but there's a massive amount of overlap between each one. So it's not all just cut and dry with one profile and that's it. There always is a little bit of an overlap, and that's why it's really important that we do an appropriate assessment of the concussion as well, to determine the profile, and then that will guide our treatment. So looking first of all at the vestibular system, it's that classical dizziness, fogginess, a little bit of nausea with certain movements, and then sensitive to certain environments. So like a moving car, you often hear people say the drive down to the clinic, doc, that was really, really tough, because their moving and their vestibular system is being challenged as part of travel in a car. From an ocular point of view, issues with kind of visual based academics, you feel pressure behind the eyes, issues with focus, and then that classical frontal headache as well, and associated fatigue. Going on to the next one, then you see fatigue coming in again from a cognitive point of view, because people find cognitive tasks quite difficult during during concussion. Okay, and then again you have that kind of headache at the end of the day. They've got symptoms because they're just wiped out, and you know, after long periods of cognitive activity, they can have some difficulties as well, and this may kind of this may bleed into issues with sleep. Again, that is coming up again. Nausea is coming up again, and then, you know, there's some photophobia and noise sensitivity as well. So things you need to be mindful of as well, that you know, we don't like these things, and they can present as a migraine as a result of that. And then the last thing is obviously the rumination that patients will experience throughout their concussion, and the worries that they have. That makes them overwhelmed, and again, sleep comes into it. And then sadness can develop, and people can fall into depression sometimes with this. And then again, the concentration issue. So it's not cut and dry, but it's important to understand that the symptoms, or the profiles of each concussion have different symptoms, and they often overlap. So when we're evaluating someone, and when they come into the clinic after they've obviously had their on pitch side, and now they're in the clinic, it's important we get a good history, because with each profile there are risk factors to them. So if you look at the vestibular system, you know, if there is a personal or family history of any kind of motion sensitivity, that may predispose them to a more of a vestibular type concussion. Equally, if there's issues with the oculomotor system, again, strabismus, nystagmus, or amblyopia, again, that may predispose them to some symptoms. From a cognitive point of view, if you think about it, if they have a learning disability, their cognitive ability will naturally be lower pre-concussion, so that will makes it more of a risk factor to a cognitive concussion. If you have a history of migraine, again, that may exacerbate migraine during concussion. And equally, if there's a mental health issues there, or issues with anxiety or the mood, they can be exacerbated during the concussion. So very important that we take a good kind of background history as well. So getting back to the assessment side of things, how do we develop an understanding of what kind of a profile this concussion has? So we first of all have to do our on-field and kind of sideline assessments. So first and foremost, rule out that spinal injury. And then we're kind of just assessing to see how they are. Are they confused? Do they have slurred speech? Is that headache there? Are they vomiting? Are there any red flags there that we need to get them straight to hospital? And then are the behavioural changes, the ataxia and the loss of consciousness there? So we need to rule out our red flags first of all on field. Once they're ruled out, then we get them off the field safely, and we start looking at symptoms. We look for physical signs of injury, obviously, and then just checking our GCS as well. That's very important. Generally, you know, after a concussion, GCS is 15 out of 15. Looking just at the cognitive Maddox questionnaires that we're all very familiar with, check and balance, and then we start looking at things like the VOMS, vestibular motor screen, and obviously clearing the cervical spine. VOMS is a really good one because it's a very quick test. Takes about 5 minutes. There's only five or six tests involved, and it's a very, very high accuracy in identifying concussion, so up to 90%. And there's plenty of research to back that up. So VOMS is a good one to have as an assessment pitch side. After that, then we get them into the clinic, and we do the more formal assessment then, which starts with the history. So what happened? What were the symptoms on the sideline at the time of injury, and then where are they now? Obviously, if there's any previous injury, any previous injury, and was it rehabilitated or not? Very important that we have baseline testing done as well, because that will give us more confidence in diagnosis. So the GAA are rolling out impact neurocognitive testing for all athletes at the moment at an intercounty level, which is great, because if they come in concussed to us, we can look at their previous baseline data and see where they are. Then we do the kind of the physical testing then, which is the balance and gait testing. The VOMS comes in there again. It's good to have a VOMS at the time of injury, and then we can continue to recheck the VOMS because it is reliable and reproducible. getting towards the end of the assessment, then when they've gone through the rehab side of things, we educate them in rehab, and then there's an exit test as well, so an exercise test to make sure that they're safe to return to play. So that's really important as well, that we exert them before they return to play, making sure that they're coming through symptom free. So the VOMS is great at identifying the kind of abnormalities and the impairments of the vestibular system and the ocular system, and those dysfunctions, I suppose, can lead to those dizziness symptoms, the vertigo type symptoms, visual, and then the issues with focusing as well. So the good thing about the VOMS is it's great at it gives us a more comprehensive evaluation. It's good at detecting things early, and then it guides our treatment as well. So it'll identify the profile and then guide the treatment. And it's great at monitoring recovery as well. So every person who comes into me, no matter whether it's the first time they're in the middle of the treatment or before discharge, they'll always get a VOMS done, because it's great. It's a great way of monitoring recovery. And then it helps with our decision making surrounding return to play as well. Much detail, but you can see from the slide there, with various different tests. It's very brief. It takes about 5 minutes, and it gives us a really good idea of what's going on from a clinical profile point of view. The great thing about the VOMS as well is it's very accurate in identifying a concussion. So if you have a score on 2 items, so we've 5 items or 6 items in the VOMS. If you have scores on 2 items on the VOMS, it can identify a concussion, and it's 83% accurate, which is very good. Going on from that, then, if you have more than 8, so we score on the VOMS from 0 to 10. So 0 is no symptoms at all, 10 is the worst you can imagine, and we do that across 4 different symptoms, and then with each test. So more than 8 on a VOMS will give us a 91% accuracy in identifying concussion. That, in addition to our history, neurocognitive testing, and all the other various balance tests and stuff that are done as well, it's a really robust way of identifying a concussion and showing us what profile we have. Which leads us on to the treatment of concussion and the various profiles. So to formulate a good treatment plan and to get a player back to return to play, or someone back to work, even back just to functioning day to day, we need to be very, very certain of the profiles and understand them, which will guide treatment. And by guiding treatment, that'll get our people back sooner than we want. So active treatment is really important as well. Okay, so if we look at, I think that slide isn't coming up. Oh, there we go. So if we look at the various profiles, we manage them in different ways. Now you can see there that they're highlighted in red. Exercise comes up for every profile apart from ocular. Okay, and what that means is that we encourage non-contact exercise with these various other profiles, because getting people moving and getting them going is actually recommended, because it's very effective in the management of a concussion. And then outside of exercise, then there's roles for different things. So from a vestibular and ocular point of view, rehabilitation is really important. From a cognitive point of view, getting some structured rest, but exercise and some medication can have a role there as well. Equally, medication can have a role with migraine and with the anxiety and mood profiles. And then you address the various profiles as you see fit, in any, as you would with any other of those profiles in a different clinical setting. So understanding profile is really important in guiding treatment, and I think Anna's going to speak now about the treatment or the rehab side of things from a concussion point of view. So I think that's me. I'm going to stop sharing the screen now, and we'll take questions at the end then.
Thanks very much, Dualtach. So I'm just going to introduce our next speaker, Anne Mucha. Anne is an expert in the assessment and rehabilitation of balance, dizziness, and visual symptoms following concussion. And she coordinates the vestibular rehabilitation for the concussion program. In addition to her clinical practice, she works in research and also serves as an adjunct faculty member at the University of Pittsburgh. With 20 years of clinical experience, and has lectured nationally on the subject of concussion, in particular the presence and treatment of balance and vestibular concerns after concussion. and holds appointments on national concussion panels for the American Physical Therapy Association, and is board certified as a neurological physical therapist. And we're delighted to have Anne with us this afternoon, and who's going to talk a little bit about her and bring some of her experience and expertise to our platform here today. So just optimal rehabilitation of concussion. Anne, you're very welcome.
Well, thank you so much for inviting me to do this. I'm always happy to talk with people that are interested in rehabilitation, especially of concussion. Can you see my screen okay?
Yes, yes, you're sharing perfectly well. Thank you.
Terrific. So it is very, very challenging to try to cover all that there is about rehabilitation and concussion in 12 minutes. I have a lot of slides. I will go quickly just to try to spark some interest, but please ask questions as you have them. Dualtach did a great job of kind of teeing me up for my talk, because I'm going to discuss rehabilitation as it relates to the profiles, but just as a general concept, which should again go with what he just discussed, is we look at generally the rest-based model for concussion is really is past. We do not rest people who have concussions. What we do is we though try to figure out what is the right level of activity. And we try to tailor it then to what their issues are. So this idea that exercise is medicine for concussion is being definitely borne out in the literature. And what we know is that if you compare individuals who are sedentary for their first few weeks after injury versus those who are activated, the outcome is quite different. And we've seen this time and time again in studies with children, in athletes, in non-athletes. So these are just some of the examples. So we know that the right activation is quite important for individuals after concussion. And then the second factor is just generally we know now early intervention overall is better. And again, multiple studies have showed that if once somebody is thought to have a concussion, is initiating clinical care is far better within the first week, is far better than those who have delayed initial evaluation. And again, we see these in different groups. Several groups have looked at this. So my take-home points are is that get them evaluated early, ideally within the first week of injury, and you need to start activating people early in the appropriate way. And that's where the rehabilitation comes into play. So I have a slightly modified version of the clinical profiles that Dualtach shared. We've worked with some different groups in the US recently, and we've created kind of a little bit of a modified clinical profile pictorial where we have basically 5 profiles of concussion, and then we have 2 moderating factors, the cervical spine and sleep issues. The descriptions of all of these apply, but what we have discovered or thought is that the cervical spine is not really a concussion, although it certainly is an overarching potential issue, as well as sleep is the same way. It has potential to really impact the concussion. But the key is, and this you did see from Dualtach, is that each of these issues, whether they're the primary profiles or the moderating factors, does have evidence-based care that has been shown to benefit managing these issues. And most of these have exercise or activation as part of that. So we need to be mindful of that. So I'm going to cover them in kind of in order. I'll talk first about the vestibular profile, just because that's the one I know the best. The vestibular profile, like we talked about earlier, is the one that's going to have individuals who are usually dizzy. Sometimes they're motion sensitive. And what we know is that there are ways that these symptoms present as issues with these 4 areas of impairment, which I'm not asking anybody to be a vestibular therapist here. But what we do is we know that each of these requires certain types of treatment and vestibular rehabilitation techniques. And we know that there's strong evidence, not just for vestibular rehabilitation, but for early vestibular rehabilitation. Again, we used to kind of use the model where if we have patients that have dizziness or vestibular deficits, we might wait and see how they do and give them, a few weeks, and maybe after 3 or 4 weeks, then we might think about sending them for some vestibular rehabilitation. And what we're seeing is that no, we really want to think about initiating that earlier. And this is the data at the top is the sport related and then the non-sport related. So this is evidence that vestibular rehabilitation is effective in this population of individuals with concussion, but that also in sport-related concussion, we've looked at the issue of earlier intervention, and it is showing that it is more beneficial. So again, rather than sitting and waiting, it does tend to be helpful to earlier rather than later intervention. You will circumvent many problems if you begin to get them managed early. And this again applies there's good efficacy for both sport and non-sport groups as far as the general rehabilitation principles, but especially in sport, we've studied that earlier is better. So I want to go into post-traumatic migraine, which is, is a whole discussion in itself because it is a little bit of a tricky profile, but one we see quite a bit, probably in the study that we did, the post-traumatic migraine profile was about 25 to 26% of the primary profiles of our individuals. So there are evidence-based treatment for migraine, and this is from the general migraine literature, and these are all the things that are evidence-based: medication, exercise, relaxation, biofeedback, cognitive behavioral therapy, and then looking at triggers. But I draw attention to in concussion, we really try to think about what are the things we can do activation-wise first before we think about medication. And these are things as a rehab professional that I look at implementing. We look at implementing the right level of exercise. We teach people, mindfulness and relaxation strategies, and educate them about triggers, but we really do get them moving in the right way. And this does require a little nuance. But what we know from good evidence is that if you are a migraine sufferer, those that have high and moderate intensity of physical activity, aerobic exercise, are much more likely to have reduced migraine duration, intensity, and disability. There's also alternative forms of exercise like yoga, Tai Chi, Pilates, etc. Those are all beneficial as well, but we know that there's a lot of evidence about having people or making sure that people who have migraines, that we train them to actually be able to utilize exercise to help manage and to reduce their migraine presentation. Now, the anxiety and mood profile, again, is highly prominent after concussion. Again, it's probably, it probably is similar to post-traumatic migraine and how frequently it will present as the driving clinical profile in our individuals based on a study that we did a few years ago. And so figuring out how to best manage the anxiety and mood profile is quite important in many of our patients. And again, there are many pharmacological and non-pharmacological evidence-based management principles for mood and anxiety issues. However, again, I'm drawing your attention to where exercise and the right type of exercise may limit somebody's need for medication or some of the other interventions, because it can sometimes really improve these factors. So we definitely implement pretty aggressive physical activity in our individuals who have mood disorders or anxiety presenting as their as a prominent factor in their recovery. The ocular profile is one that is probably not as familiar to many of our practitioners, just because, vision is vision, and usually that's left to optometry, but we see a lot of oculomotor issues after a concussion. And we know that we're trying to it's not usually an actual visual visual impairment in that you have trouble seeing. The issues after concussion are usually related to binocular vision dysfunction. So it's about the working of your eyes together that seems to be the issue after concussion. So this would be manifest in things like problems with pursuit eye movements or saccadic eye movements or convergence or divergence eye movements. we do a lot of training for these binocular vision dysfunctions in physical therapy here in the United States. We will do activities, some of them higher tech, some of them low tech. But what we also do is we act as kind of a gatekeeper for who may need to actually have more specialized vision referrals, because sometimes we do need to do that. And so having a behavioral optometrist is who usually specializes here in the US, but that may be implementing more higher tech or more evaluations that are a little more detailed than what we can do. But often patients who have mild to moderate problems respond well with physio. And there is evidence, there's not as much evidence on oculomotor rehab as there is with vestibular rehab, but there is evidence about these oculomotor issues do respond to management after concussion. I'd like to talk to you about the cognitive profile in that we need more information about this one. This is the one that we're lacking the most data on related to rehabilitation and activity and just management in general from a concussion standpoint. So we take a lot of our information from some parallel conditions as well as just some of the literature related to mild and moderate type of brain injury. But what we do, at least here in our clinic, is when we have people that have strong cognitive profiles, again, we're trying to improve activation. So exercise, the right exercise is important, and the right schedule regulation and activity regulation is quite important. Again, we typically don't use much medication anymore. We used to use stimulants early on, but then we kind of got wise to the fact of we can actually get a better effect and a healthier effect if we just try to leverage the right physical activity in a way that benefits them and increases their energy and their cognition. The other thing we do with the cognitive profile is we really try to clear away the things that could be influencing or interfering with cognition. So for example, if you're having a lot of headaches or migraines, your cognitive function is going to be lower. And sometimes the cognitive effects are secondary to those primary effects. So if we get rid of the primary issues, then often the cognitive issues will resolve. I probably don't need to talk much about the cervical moderating issues to this group, but we know that cervical is a huge overlay in concussion because you can often have cervical injury and concussion injury, and sometimes it's hard to know where one begins and the other ends, and they're often entangled together. So the same idea applies with cervical spine management. We need to think about how do we activate or create the right environment for the cervical issues to be resolved. And of course, this often involves things like manual therapy and the right types of exercise to balance musculature, as well as other types of interventions that we could provide if these things aren't working. And then the final factor is sleep, which is a bit of a beast in that if you think about sleep and if there's impairment after concussion, it can be a few different types of things. One is that sometimes people are just very sleepy all the time and they're sleeping much too much, especially in the daytime. There might be issues with initiating sleep. There might be difficulty with maintaining sleep or just fragmented sleep. But the key here is that this is the one issue that will affect all of those profiles of concussion. And it's a little bidirectional when you think of things like the anxiety or mood or the headache or the vestibular system. If those are activated, they may also go back and impair sleep at night. And so we have a lot of, there's a lot of value in trying to improve sleep. This is all of the evidence-based managements for sleep impairment, leading from cognitive behavioral interventions all the way down into other types of things like hypnotherapy. But again, I will draw your attention to the fact that if you are not activated appropriately in the day, you are not going to be sleepy at night and you're not going to be regulated to sleep at night. So making sure that your individuals have a good sleep routine, that they're active enough so that they do want to fall asleep at night, and then perhaps introducing some of the other mindfulness or some of the meditative movements or even CBT type principles or even specific programs is really helpful in managing sleep, even before we need to think about pharmacology. So just in summary, in this brief talk, we certainly find value in identifying those clinical profiles to manage concussion, because not every patient needs every type of intervention, but that there's active evidence-based treatments for each of these profile and moderating factors. So the ones that are the most important in your patients, we need to think about implementing. And the most recent evidence supports that earlier treatment, earlier intervention supports optimal outcomes in our patients. So I think I'm going to leave it there.
Thank you very much, Anne. That's yeah, you've covered everything in record time. So hopefully we have a few minutes now just to go through a few things. And again, I'd ask anybody who's any questions for Anne before she leaves, if you want to just go through the Q&A, and we'll try and get Anne to answer those from anybody. So just I just have a couple of questions that I think may be relevant to our registrants today. So the first thing is that baseline testing. I mean, how important is it when you come to rehabilitation from concussion that you have in your possession a baseline concussion assessment that gives you some idea of what the patient was like before injury, and does that give you then the benchmark of when the patient is essentially normal following their treatment? And so how useful is that?
So I'll let Dualtach also weigh in, but from our standpoint, we find it helpful, but not critical, because we don't use cognitive testing alone. We're looking at multiple things when we evaluate a concussion and determine recovery. So while more data is always helpful, especially, I would say especially in our younger patients who their cognitive function is sometimes developing and it's variable. It's good to have that benchmark. It does definitely enhance what how we can make decisions about return to play. But we do have normative data that helps us quite a bit. You can go historically on things, and as we talked about, we don't just use we use things like we look at their general symptom reports, we look at exertional testing, we look at the VOMs and vestibular testing. So we aren't only relying on one piece of data anyhow. Dualtach, do you have any thoughts on that?
Yeah, I'd agree with that entirely, Anne. I think it's a multifactorial thing. The more information we have, the better. But the one particular test or the one particular baseline test isn't gonna determine whether someone's back at their baseline or not. I think it's all to do with symptom reporting, the VOMs, exertional testing, everything Anne mentioned. I think the more information we have, the better. But it's not critical.
And do you regarding the cognitive testing, is there different time points where you may have abnormal cognitive behavior? I mean, is it always worse at the start and tends to get better, or is there sometimes delayed issues with the cognitive ability of people that's not maybe picked up initially that comes later?
Go on, yeah. I suppose it's an interesting question, Pat. Like, concussion does tend to evolve. My own experience is that if someone's engaging well with the rehab and treatment is going well, that the neurocognitive test or the impact test tends to follow a pathway that's improving. People do tend to hit roadblocks and stuff like that, and they can disimprove as well. But generally, if rehab is going well and everything's going in the right direction, you see an improving pattern to it.
Okay, and so what would be the most common reason for somebody who has delayed presentation? So, for example, you could have an element of a concussion from a football match and cleared fairly quickly, and it may be a number of weeks before you realise that everything's not quite right. I mean, regarding delayed presentation for people for doctors, physiotherapists to look out for, what will be the most common types of delayed presentation that you should be worried about?
Just one thing that we have seen is, and this is why it's important to make sure people are removed from activity even when there's a suspected concussion, because there can be delay. I would say one of the more common ones is migraine, that you might not see the migraine develop for a few days until people begin to get activated again. Sometimes what happens is you kind of take it easy for a day or two, and then once you get back into full routine and that load starts to weigh, then sometimes migraines will come into play. That would be a common one that we've observed.
Yeah, I'd agree with Dan there, and I think another thing is just from a cognitive point of view, and we're seeing a lot of well, it's kind of quieting down now, but a lot of kind of secondary school students where they may be struggling a little bit in school as well, and the cognitive things. The teachers are noticing things, and then that migraine pattern can develop as well. So, that's when they start to present to us. So, you know, a week or two later, they're just not quite right, and they're beginning to return to sport, and it's just not all making sense. So that's when they generally tend to present to us then.
Okay, and we have a question here from one of the delegates, which I'll come to now in a second because it's linked to what I'm going to ask. Is the VOMS system of assessment of the vestibular ocular, is this something that is being taught to physiotherapists and doctors in Pittsburgh and across the country? Is it available if people want to make contact? You know, because obviously it's not something that everybody will know how to do just from the outset. It's obviously, and is that something that, Anne, in Pittsburgh, you're focused on, really, to trying to get that level of assessment out to lots of clubs and lots of doctors and physiotherapists around the country?
Yeah, we sure are. So first of all, it was developed in 2014. So there's the original article was in the American Journal of Sports Medicine, and it details all the instructions as part of the article, and so it is non-proprietary. Anybody can use it. It is quite easy to administer. You just need to follow the instructions. It is, we definitely, I would say in the US, most programs now teach the VOMS as far as in the physical therapy schools. It's just a nice thing to have in your toolkit. It's quite easy to use. It's not high tech, it's very low tech, and it doesn't take long. So it's a good screening tool. So all of those things make it kind of very user friendly, and again, just Dualtach had said that it also can help as you're monitoring progress to some degree, you know. So I think that those types of tools can be useful in your arsenal in managing this injury. So yes, we encourage everybody to get a little educated on it and use it as you see fit. We'd love to have it in everybody's clinics.
Until, did you see it the same in Ireland? Do you think, you know, when patients refer to that, it's fairly widespread that they've already had a VOMS assessment?
It'd be very rare that I'd have someone refer to me having had a VOMS done, unless they've kind of attended some of the GAA stuff. I know the GAA on their website have access. You can access the VOMS through the concussion part of the website there. So it'd be very rare that we would have a VOMS with the patient who's referred to us. But like Anne said, it's very quick. It's very easy to administer. It gives us a lot of information, and it's a good place to start from. So you know, I think if you even just put it into Google, it'll come up straight away. The instructions there are very simple on how to administer it, and it gives us more information, and it may even you know, help the clinician that's referring in be able to give us an idea of what profile we're dealing with, so we can get going, you know, starting or quicker.
And the best time to do the VOMS would be, for example, if a player's been taken off the field, would be to do it straight away, or is there a better time, leaving it for 24 hours, or is it straight away? The signs should be present right from the start.
Yeah, like I think you should do it straight away. But personally, I think straight away, and like it's so quick to do, and it's 5 minutes. I think you start it then, and then you can, like I was saying in the talk, it's reproducible, it's reliable. So it's a good way, not the only way of monitoring progress, but a good way of keeping an eye on how things are progressing, and even how the concussion may be evolving as well. So the sooner it's done, and then the more frequently it's done, I think it's no harm.
Okay, and just a question there from one of the delegates. Any other other than VOM, sorry, any other vestibular test that you would find most useful?
Well, there's a whole battery of things that we'll do clinically that are looking at vestibulo-ocular reflex activity. We're looking at, we may be looking at eye movements a little bit more in detail. We might be looking at benign positional vertigo. So that goes into, there's a lot of things that we may use as an in-office practitioner that go beyond kind of the VOMs. And they're basically taking those items on the VOMs and just kind of expanding them out. So there are tests that the VOMs is based on. So like there's things called gaze stabilization testing or dynamic visual acuity testing, things like that could be helpful. So.
Okay, and just one more question here. How does the VOMs compare to SCAT-5 assessment?
So they're completely different. Okay. The SCAT-5 does at this time, and if the most recent consensus statement and the recommendations, there was a lot of battle about whether to actually include the VOMs in the SCAT-5. And it's a very odd process. There's voting and everything, and I think it fell just slightly short of it. The thing that we know about the VOMs, there's a couple of articles that came out recently that actually look at a modified version. It's a shortened version of the VOMs. It is meant to be more for sideline use. So it's even an abbreviated, and the idea is it's just identifying the injury, and that's what we're looking at. So there was talk about whether that should be added. The military here in the U.S. does add that to their on-field or their in theater assessments, but it is not in the SCAT. And I think that especially when you go to the first in-office clinical assessment, the fact that there's really not anything that looks at vestibular and ocular function in a way on the SCAT, I think that you need to do both things.
Okay, and so just another question here. Is there a way to monitor the level of activity as we encourage people to stay active? Is it just to the level of not increasing symptoms?
Oh boy. How much more time do we have here? So I'm going to be a little rogue here because we may do things a little bit differently in my clinic, but we have quite a number of years and a number of patients to go off of. But we do not subscribe to the idea of not provoking symptoms with activity. As rehab professionals, that when you're strengthening people, you don't go by the mantra of that you can't cause any soreness, you can't cause any discomfort. But what you do have to do is make sure that that patient is getting stronger. They are getting better by the activities that you're doing. So it's not about immediate symptoms. And unfortunately, a lot of our guidelines are really about don't provoke any symptoms. So I would just caution to not be too concerned about provoking any symptoms. However, you need to make sure your patient is improving over time with the intervention so that those symptoms need to improve as you are exposing to activity. And that's where it is a little bit of a nuance, because we will treat somebody that's got a lot of migraine proclivity very different than somebody who's just anxious or depressed. We might allow a person that's anxious and depressed without migraine to really push into a lot of symptoms. But somebody that's a migrainer, we may not let them have as much symptom provocation. We still may let them have some, but we might not let them have as much, because producing more and more migraine is not productive. We want to improve their migraine profile. So that's where the rehab professionals, we will still have jobs for a long time in this injury.
That's grand. And just another question, just regarding the use of MRI to help diagnose potentially the extent of underlying brain injury. Is it undertaken from a concussion point of view regularly or not regularly? Is it helpful for establishing the sort of the severity of the injury and rehabilitation?
I personally, we don't use MRI at all, Pat. If we kind of go back to the start of the talk, and concussion is generally something that happens at a cellular level. So it's it is a traumatic brain injury, but it's not something that happens kind of from a structural point of view. The only time we would do an MRI or any kind of neuroimaging is if we're trying to rule out an organic cause. So if the person who presents with what we think is a concussion goes through the concussion treatment pathway and isn't improving, we may then look at doing some sort of imaging to rule out some sort of pathology. But from a concussion point of view, it's not something that's routinely done.
Okay, and you'd agree with that?
Same, yes.
That's great. Well, look, we've got we've a few minutes left. We're going to just go through the paper that we emailed out. And I know you're very busy, and thanks very much for your time and your expertise. It's been fantastic. So and if there's any further questions come through, we'll be able to hopefully maybe field them on to you and maybe get some answers from you. But again, thanks, Anne, for your time. And Dul, you're going to stay with us then.
We will, yeah. Thanks, Anne.
For the
Thanks
paper.
for the insight and the expertise.
Bye now. So I'm going to so Karen's going to share her screen and just and bring up just a review of the paper. We're not going to spend too much time dwelling on the paper. It was a good paper with a very useful title, so we thought we'd introduce it, and so we'll see just what we thought of the paper.
Yeah, welcome to this month's webinar. This paper that we're discussing this month is Concussion Increases Within Player Injury Risk in Male Professional Rugby Union. This was by Moore and colleagues last year. The aim of the study was to assess within player and between player injury risks associated with concussive and non-concussive injuries that commonly occur in professional rugby union. And the first team players from 4 provincial male rugby union teams in Wales participated. It was an injury surveillance carried out over 7 seasons, and all time loss injuries were recorded in a specific database. And time loss injuries were defined as injuries resulting from non-participation of rugby training, match, training or play for at least 24 hours following midnight of the injury event. For the stats, they looked at, the match incidence was 3-letter OSIS code, which is calculated using an estimated match exposure. And 5 highest injury match incidents were referred to as the common injuries. And these were concussion, thigh hematoma, hamstring strain, AC joint injuries, and lateral ankle sprain. The injury risk was calculated using proportional hazards, and within player change from their pre-injury risk was calculated, and between injury subsequent risk was looked at using hazard ratios also. In total, there was 2,888 injuries sustained in 382 players, the concussion being one of the highest incidences. And based on time loss data, the thigh hematomas had the lowest severity, and the concussion and lateral ankle sprains had a lower severity than AC joints, but the rest were kind of similar. Concussion was the only injury to increase within player injury risks, with players at a 26% greater injury risk of injury post-concussion compared to pre-concussion. And in contrast, lateral ankle sprains decreased within player injury risk by 30%. Figure 2 kind of shows that on a graph looking at the hazard ratio. So as you can see there, the concussion increased the odds, whereas the lateral ankle sprain decreased the odds. Similarly, compared with non-concussive injuries, concussion led to a 24% greater between player injury risk. And figure 3 shows that also, as you can see again, the concussion increased the odds compared to a lateral ankle sprain. Concussion also decreased the median time between injuries, so it had the lowest time to the next injury compared to all of the rest injuries. It was 39 days, that was the median time, which was lower than all the rest. The author limitations, so they did not take into account injuries that may have occurred while playing international. They were male only. The individual level exposure data was unavailable. Only the top 5 common injuries were examined, and only lateral ankle sprains and hamstring muscle injuries were analysed. The authors concluded that concussion was the only common injury that resulted in elevated within player injury risk and shortened the time to next injury. Lateral ankle sprains led to a reduction in within player injury risk. Concussion return to play cause should be re-evaluated to mitigate the increase in within player injury risk, particularly for head, neck and neurological injuries. That's just a brief explanation because I know we're short on time, so I'll hand you back to Mr. Carton and Dualtach for any questions or discussions on the paper.
Thanks, Karen. So we're just going to put through a few of some of the current concerns that we have, as a group, have regarding the paper. And before we just do that, I mean, Dualtach, is it reasonably well known that that if you have a concussion injury, that you're more likely to have an injury of either another musculoskeletal injury or another concussion injury? Is it generally well known in the literature that that is the case, that concussion sets you up potentially for having further injuries in the field? But just before, because that was brought up in the background here, but it's not something that I'm completely aware of whether that's true or not. Is it something that you've been aware of?
That's probably it's a bit of a bone of contention, Pat. Like, if you think about it, you can be concussed and return to play, and return to play without any rehab, without being back at your baseline. So I suppose that the question is somebody more predisposed to injury if they've returned to play and they're not back at the baseline and not rehabilitated? So to answer your question, I think there's probably two factors that really need to be looked at. Has the person been just returned to play after taking 3 weeks off, or have they gone through a rehab program, returned to their baseline, and then we know that they're at the baseline, so they shouldn't be more predisposed to any particular type of injury. So I think that's probably the question we should be asking in the literature, as opposed to, is somebody predisposed to more injury because they've been concussed? Because there's a lot of people out there that aren't being rehabilitated and they've just been thrown back in. And I think that kind of is a little bit evident in the paper as well. But I suppose to answer your question, I'm not familiar with concussion predisposing people to injury, but you have to caveat that with some people may be predisposed to injury because they're not rehabilitated correctly or not returned to the baseline.
I think that's an important point. I mean, the study doesn't indicate whether any of these players actually had formal treatment for their concussion and had returned at a level where they were clear for play. You'd expect at this professional level that they probably would, but it wasn't made clear. Yeah. I think one of the other things about the paper that when you read the paper, it's a nice paper. It's an observational study, simply looking at the prevalence of post-concussion or non-concussion injuries over a period of time. And a few things that I picked up on. One of the things I think would be more important is that at what time point in the study do the concussions occur? Because obviously, if you have a player who's playing 7 seasons and they have a concussion in the last season, there's not going to be a lot of time there for that person to have more injuries. Whereas if the concussions were recorded early in a player's career, then obviously there's going to be a lot more time to have further injuries. So I think the time point of when the concussions happened would be important, and we didn't get information regarding that. Second thing is the age of a concussion. So if you've got somebody, are younger players more likely to have a higher chance of being concussed? Are they more aggressive in their play? They take more risks? Because again, if they're younger and there's a lot more career opportunity afterwards, their increased risk of post-concussion injuries are going to be higher. And then the number of seasons the player was actually playing for. I mean, what they've said is in their study that if they weren't listed for the team that season, then they weren't included in that particular year, or if they were playing matches for outside of the club, then the injuries sustained at those matches weren't recorded. So they could have been playing and had injuries that weren't recorded also if they weren't listed on the first team. So I think there's a lot of areas of this that lead to inaccuracy in the data, and so the severity of the injury again how do you measure severity of concussion? Because obviously, a very mild concussion versus a much more severe protracted concussion is going to have a higher emphasis on the chance of having further injuries. And then the last thing was the exposure. It was the actual amount of time the player actually was playing was not recorded. So the fact that the player was listed to play at the start of the season, they assumed that all players then had the same exposure for that year, which we know is completely inaccurate. So if the player is off for any other slight injury, they're not going to have the same exposure. If they're on a subs bench, not getting played, not the same exposure. So there's a lot of things there that a lot of unknowns that I feel that really take away from the accuracy of the results. And the last thing is player position. mean, is it much more likely there are certain positions in the rugby field you're more likely to get concussion? Is there any data on that that you're aware of?
Not particularly, Pat. I think that's probably something that needs to be looked into. That, you know, the paper didn't touch on it. Is, you know, if you're a forward or if you're a back, you know, does that predispose you more to concussion? And I think that goes across all sports as well. I think the risk that players take by playing any particular sport, it's probably similar. But I'd imagine that if you were to break it down, that specifically in rugby, that to be more, you'd be more predisposed to it based on your playing position. That's not touched on in the paper, and I think that's probably something that needs to be, excuse me, needs to be addressed.
Just before we go, I just want to ask one last question regarding the region. When you have a concussion, is there any evidence that the type of symptoms you're going to get will be related to the mechanism of the concussion? For example, a fall backwards onto the back of the head, or a head-on collision into the forehead, or a lateral strike. I mean, do they tend to match up with certain profiles? Generally
not. No. It's every individual is different. If, you know, two people have a head-on collision, one person might even have a concussion, the other person might be concussed in a different way, and equally the profile that two people with the same kind of mechanism could be completely different.
Okay,
so I don't think there's anything to suggest.
Okay, so the mechanism or the pattern of cellular damage in the brain doesn't seem to localize the symptoms clearly for most of these patients.
Not that I'm aware of, anyways.
Okay, Dualtach, listen, thanks for giving us your time, and it's always great to discuss concussion. It's always something that's it's a massively important part of our sports management, diagnosis, and treatment. So thanks for giving us your time. Very much appreciated. And to Anne Mucha, and so hopefully everybody can join us again next month for our 6th installment, where we're looking at knee ligament injuries. But and thanks to Karen and David, our research team, who helped support the webinar. So hopefully now you're up to date on concussion. Thank you very much, everybody. Thank you.